The Core 360 belt is the best aid to train the abdominal wall. The Core 360 is a patent-pending, first-of-its-kind training belt that helps you move, breathe, and perform better. We use the Core 360 belt with almost every patient at Winchester Spine and Sport. The biofeedback is second to none, and it's an amazing way to teach proper respiration and can be even used during higher-level movements in the gym. Teaching proper respiration is about as fun as a rash, but with the Core 360 belt, you take all the headaches away. Visit core360belt.com and use the code GESTALT for 10% off all belts, ohm track sensors not included. Again, visit core360, core360belt.com and use the code GESTALT for 10% off. Enjoy the episode. All right, everyone. Welcome to another episode of the Gestalt Education Show. We're kind of finishing up our tour of Caesar's Palace today, Brett. We've done some awesome podcasts. Man, oh man, we kind of talked to almost everybody, and so what a random occurrence has happened. But this has been someone on our list that we've been looking to have on the podcast. We've been trying to get down to Miami to see him. It just hasn't worked out, but he happened to be teaching a course here in Vegas the same time we are. So Dr. Yoav. So I first heard about you from my good friend Jake Alec, and he's actually the one that kind of hooked this all up together. He sent me, when I was starting to get into MDT, he sent me this random YouTube video. And sure enough, it's Dr. Yoav talking about mechanical back pain. Was it to a corporate group or?
No, this actually was, this is a talk that I did to market my business starting in Miami when I moved from New York to Miami in 2008. And I started promoting my services to the general public. And this is the talk that I started to do, Understanding Lower Back Pain in Sciatica. Now you can see it on YouTube. And it was a free educational talk where you come to Whole Foods. They had a cork board. I advertised, come join me for a free educational breakfast. Brought my spine models, like Treat Your Own Back book. And people just joined me. And then from Friday to Friday, it became busier and busier. And then at the end of the talk, people like, so what should I do for my back pain? What should I do for my sciatica? I was like, I don't know. I have to evaluate you in my office. I'm not going to undress you and start doing the assessment here.
Right here at Whole Foods. I mean, my God.
And that's when I was like, I owe you a solid evaluation because what I give you may hurt you. And so that's how I funnel people into my office. And one thing led to the other, and it was all word of mouth. And here we are.
I love it.
So Yoav, everyone's kind of got a crazy story on how they end up in McKinsey. So what's your story?
My career started as a pretty mediocre, kind of dumb personal trainer. Took me 2 weeks to become a trainer. Unfortunately, in this country, I was making six figures in my 20s, injuring clients left and right, stretching people who had neurological issues, leaning on my clients, telling them to sit in a hot bath with Epsom salts when they had a spinal derangement, hug knees to chest, posterior pelvic tilts, bridging, cat-cow, opposite arm and leg. Everyone got what we think is
the playbook. You get the playbook.
And then I went to NYU, did my doctorate in physical therapy, and at the end of the program, one of my professors said, come work for me. And I started actually with pelvic floor courses and trigger points, etc. And then one day she said, there's a Part A in Syracuse, New York, McKenzie Part A. Are you interested in taking it? And I was like, yeah, of course. So she's paying for it. I'm going to go take the course. So I took the course with Dana Green, loved it. Immediately went into Part B because I knew it's the neck. And I myself had 8 months of intermittent pain, left neck, left upper trap, left shoulder blade radiating intermittently into my arm. Bothered me, annoying. Kept stretching to the right, leaning against doors, trigger points, tennis balls, everything just to get the relief. And I would get a temporary relief and it will come back. Obstructed to left rotation, right was normal. And here I am in the course. And as Dana Green is talking, I'm moving in the sagittal plane and I get worse. And then it gets to the point of a relevant lateral component. And I'm like, interesting. Maybe I am a relevant lateral. And all of a sudden, I started to go into the pain. And because I always stretch to the right, that was easy for me. But when I had to go into the pain on the left, I mean, you see stars. And normal human beings, when you laterally flex to the left, you should only feel a soft tissue stretch on the right. I felt something on the left side of the neck. Now, you can argue what it is that I felt, right? There's disagreement around the world
Of course.
as far as what it is. And that's and 200 reps and overpressure, and this got better, and the following day I'm doing it again. And here I am, going into the pain, and I was fixed. And when I saw the light, I was like, I have to study this. And I started taking C and D and C and D again. I started visiting courses and volunteering. And at the end became faculty for the McKenzie Institute, and now I'm a senior faculty. And there's nothing I love more than sharing this story on the stage when I teach students. So, that's where we are right now.
And we're good friends with Scott, and one thing he's taught us very well is kind of the downsides of MDT are not enough reps, not going to end range, and then going lateral too soon, actually. So what are some other hang-ups, do you think, like when you're working with people that are getting introduced to MDT, what are the mistakes they're making?
There's another one, if you want to add to the 3 curses. We used to always teach the 3 curses of MDT: not doing enough reps, not going to end range, going lateral too soon. Another one people forget about is forgetting to use sustained position.
Yeah,
That's huge. Remember, Mr. Smith, when McKenzie pretty much developed the method, Mr. Smith laid in sustained extension. Now, people forget that lying prone is sustained. There's people who are jumping into doing press-ups, and that's coming back to bite you if you don't hang out prone. In some cases, lying prone in extension, or what some people call prone on elbows. If you don't go through these 2 stages before you push into end range, it may come to bite you. So too fast, too soon. So a clinical pearl: don't forget to use sustained position.
I know there's no hardcore rules, but who's the patient profile that you've noticed that does respond to sustained off elbows?
Those that have more severe derangements.
Okay.
Those that are the acute, more severe derangements, they're gonna need more time to go between lying prone in extension, especially if the patient has one of the 3 deformities, which is, as we know, we have acute kyphotic deformity, acute lordotic deformity, and acute lateral shift deformity. The acute kyphotic deformity are going to need a long time. The session's going to take an hour and a half, maybe 2 hours to slowly get them back into sustained. So these people will not respond to repeated, they will respond to sustained.
Do you ever use sustained in the extremities or only in the spine?
No, you use sustained in the knees, you sustain sometimes in the hips, based on the symptomatic response. Definitely, you may start with repeated, but you will end up with sustained.
Will the response always be produced no worse, or what's the response that maybe makes you think, oh, okay, I need to add some sustains here?
So it will be decrease no better or abolish no better. So yellow light, where the joint loves to go there, but it doesn't hold. So if you have to stick something to the wall and it falls down, what are you going to do next? You're going to put it, hold it there, and then it will stick. Yeah. And often, we teach students, if you get decrease no better, abolish no better, the joint loves to go there. What's missing is either sustain, making sure the patient goes to end range, or both of those.
Yeah, that's perfect. Yeah. And then let's kind of take it, even make it a little bit off of MDT. So in your practice, you're in Miami.
Yes,
I'm sure your patient profile is awesome, but you've started to kind of dip your toes into a little bit more corporate stuff as well.
So during the pandemic, I rented my office for 10 years, and then in January 2020, I bought my office. So here I have a mortgage. Pandemic started officially, let's say, March 2020. April 2020, no one's coming to my office. So I'm like, shit, what do I do now? And then I happened to get a text from one of my former clients, who's a CEO of a big company. It's like, listen, I have all these people working from home now, and I'm getting complaints. Our HR department is getting complaints of neck and back pain. And he's like, I invested all this money in ergonomics in the office, but I don't know how they're working from home. It's like, would you do an educational talk like you did on YouTube? Can you do an educational talk to my employees? Sure enough, we organized a Zoom call, and we had close to 400 people. And people work from home, and I asked a few of them to show us where they're working. People work from their bed, people work from their sofa, people work from...
Oh, the shit you see in people's houses?
It's unreal.
Yeah.
I mean,
You know, people have these great chairs at the office, high-low desk, and then people are sitting, on their, laptops like so. And so we talked about mechanical pain. Mechanical pain, as you guys know, is the most common pain human beings feel in their lifetime. Everyone has felt it. And if they haven't felt it, they'll probably will feel it. And so we talked about prevention strategies and how you should hang out while working from home. What one must know in terms of, where should your hips be in relationship to your knees? Where should your head be? Where should your elbows be? What to do when should you look at your phone this way or should you look at your phone this way? All these things have an effect. When you guys talk to patients, you know that they do those things all the time. And if you found a directional preference in the neck, if someone responds to retraction, extension with overpressure, it makes no sense for them to leave your office and check their freaking emails as they're going back to the car.
Right.
Because they're undoing what they just paid you to do.
Right.
So people have to understand the carryover. Remember, guys, you can have golden hands. The damage occurs when the patient leave your office. And if they don't understand cause and effect of mechanics, you can't really continue to get better. Now, obviously, it can create dependency, which some people would love to have. But I'm all about trying to figure out what the patient can do on their own. And that was one of the brilliance of Robin McKenzie. He pretty much figured out that his patients need to do, whether you want to call it self-mobilization, self-chiropractic, self-care, self-adjustment, however you want to attack this. Patients have to do things on their own. And so the corporate education took over once I explained. I created this kind of like a studio in my office. Actually, 2 weeks ago, I had 1,100 people with, OPTP.
Yeah.
They're the publisher of my book,
Yeah.
of Aging Without Aching. And we did Zoom Live, and it was both platforms, was Zoom and Facebook Live. And they joined both platforms together. We had a huge response from the audience. We're actually going to do a Q&A coming up.
That's awesome.
And it went really well. And so people sent questions. We didn't have enough time, but the whole education through the internet, through webinars, is something that has grown tremendously in my business during the pandemic.
That's great.
I was just going to say, it seems like all you instructors all have like great Robin McKenzie stories. What's one of your favorite with the time spent with Robin? What are some?
So I met him first in 2007 in a conference in New Zealand, and then one day I had a client named Harry Dornbush, a patient. I can mention his name because we did a CBS segment. Harry came to me shifted, 7:30 at night. 2 hours later, I'm correcting his shift. The guy almost passes out from the pain. Helped him. He was super thankful, and he's like, listen, I'm connected in CBS. Let me help you do CBS Miami, which is also on YouTube. You can do a segment to promote the McKenzie method. One day I'm sitting at work, and I'm opening my email. Your emails come in, and all of a sudden you see an email, and I wonder if I can find it here, from Robin McKenzie. Let me see you see from Robin McKenzie, and you're sure someone is shitting you.
Yeah. Someone's screwing with you. Yeah.
Someone's screwing with you. It's like, and honestly, I don't know if I'll find it on my phone. I know it's on my computer. Robin McKenzie. Dear, let's see.
Do not delete that.
Yeah, no joke.
Dear you, let me see. This is on my phone. There's not great reception here. Let's see. It was something like, Dear Yoav, here we go. This was sent to me August 19, 2010. I'm like dry mouth, shaking.
Like, yeah, what did I do wrong? Generate.
Dear Yoav, I was most impressed with your new news clip on CBS. Your presentation, your appearance, and very clear explanation were perfect. I'm really impressed. What are the chances of the Institute being able to use the clip for our websites? Obviously, it is now in public domain, but I would like to know your feeling regarding the future possibility of using it for the benefit of MDT. Also, I wonder if you would agree to enter discussions with me regarding producing a DVD for promotional presentation based on Treat Your Own Back. So I'm like, and then I email him back, and he's like, would you consider coming to New Zealand? I'm like, would I consider coming to New Zealand? I'm buying a ticket.
Yeah, I'm already there for it. Yeah.
So that's how it was great. And, I sat and read and wrote the script based on his best-selling book, Treat Your Own Back, which was sold in the millions worldwide in 19 languages. I mean, the man was a genius. He really figured, was voted the most influential clinician in orthopedic care in the United States. And so we converted the book into a DVD. And it was selling, now no one really watches DVDs anymore, but it was selling for about 10 years on Amazon and OPTP. And that was great. I flew there, interviewed him. The interview, by the way, guys, is open to the public. It's on YouTube. It's about 20 minutes. And it was just great to sit with the giant, ask him questions, and,
One thing we do on our podcast, Yoav, too, is we try to, when we get these people, we want to know what makes them great clinicians. So what do you think Robin McKenzie, what were his greatest attributes that really made him world-class in the ability to treat people?
Robin had one question that I think is extremely, extremely powerful. You can see it if you go on some of the videos that McKenzie has on YouTube. There's one sentence where he asks a patient, and we were in New Zealand in 2007, and he asked the lady on the stage, he gave her, and it's a loaded question. He says to her, if your pain turns on, can you stop it by doing this exercise? Now think what an atomic bomb it is to give it to a patient. Because basically, if the patient felt better in the office with a specific exercise, and that patient right now is having the tools to take care of themselves at home, and they say yes, you have a buy-in for the patient to do their home exercise program every 1-2 hours.
Yeah.
And so that was the biggest thing. I think it was the empowerment, the ability of Robin to convince the patient they can take care of themselves.
Yeah. Let's jump off into some derangement and the new definition of derangement. So I got a tough question for you. Do you think that movement obstruction has to be part of the derangement?
We actually changed the definition. Often there is a movement obstruction, but not always.
Right.
Yeah, so...
Well, yeah, it's interesting. We talk a lot about this in manipulation, that sometimes when we're moving joints, there's also a neurophysiologic benefit. So the reason I actually heard Richard Rosedale talk about this, where, you have people with, that have random elbow pain. And, if we move their neck, they may not actually look like they have a movement obstruction in their cervical spine. Mm-hmm. However, you do 100 retractions, all of a sudden they're like, well, my elbow's better. So then it kind of questions the original, definition of the derangement. So I'm curious, what's your opinion on all that? I mean, because it makes it easier to teach, honestly, if there is a movement obstruction in every derangement.
Sure, but that's one of the reasons we changed the definition.
Yeah.
So it's a clinical phenomena that requires directional preference. Usually there's going to be a movement loss, but not always.
Right.
In the spine, you will often see, or about 50% of patients will also show centralization. So, if that happens, calm your patient down. That's a good thing.
Yeah.
If the elbow pain becomes shoulder pain or the shoulder pain becomes neck pain, pull out the book. Tell them that centralization is a good thing. And again, there's not enough research on the cervical spine where centralization can occur. Lumbar spine, there's heavy research to support it.
With the second most common classification being other, I think, McKinsey's now kind of like, I feel like dipping their toe into some of the other, things. And what's the future, do you think? I mean, you think we're going to, is 10 to 20 years from now, does MDT look exactly the same? Or is it going to continue to evolve to where, we start tackling some of those things in that other, or it's so powerful, let's just keep it clean how it is right now?
I think the fact that it changed from derangement, dysfunction, posture, other, to derangement, other, dysfunction, posture, that's a huge change. And we all agree on it. As faculty, we meet, and we discuss it. And so that's what we see in the clinic, and that's what we need to, teach our students what to do when someone comes to you with mechanically unresponsive radicular syndrome. I'll give you an example. I have a 34-year-old lady right now. She came to me with leg pain. She has a foot drop. Pain is gone. Foot drop, no change. She goes to a surgeon for an opinion. The surgeon's like, Yoav, we got to operate on her. I'm like, I'm going to work with the patient. I'm going to do whatever the patient wants. What do you want to do? She's like, I don't want to have surgery. You killed my pain. I'm like, but you still have foot drop. You still cannot wear the shoes you want to wear. She wears a little bit of heels or platforms, and she can fall. Like, she literally doesn't have dorsiflexion. So I'm like, listen, I'm 50-50. I want to work with you, but I'm telling you, I've done everything I can. I'm not able to change it. I think you're a good surgical candidate. So MDT, when we go into the other, and she's an other, MDT has to give the right recommendation. I think what's going to change in our education will be, how do we help patients make the right decision? Unfortunately, in America, so many patients are led to believe that surgery is the only solution. Unfortunately, so many patients have MRIs. The doctor just look at the findings and say, we have to operate on you. The patient doesn't even have to be in the room, and they decide to do something for the patient. So the other is something it's definitely in the forefront now, above dysfunction, above posture, and I think it's going to stay there for a while.
And a lot of that is like the certainty of the clinician. I feel like like whether or not they're going to listen to you on the advice you're talking about is how much you can empower the patient. And that's a tough thing to teach your students, like to have that confidence and certainty. But I think like with MDT, it's such a powerful system that it almost like bakes it into the cake to have that certainty with the patients.
Yeah, and that's experience. Look, I tell the students, even now in this course, Part A, I said, guys, you'll go A, B, C, D, get certified, but you really will get better if you take the courses again and again.
Oh.
Right?
Yes.
You guys took it with other instructors.
Oh,
You
yeah.
always pick something up. And so if
Always.
you love mechanical diagnosis and therapy, if you love MDT, keep taking the courses. Anyway, you have to spend money, on continuing education. And, people are like, I want to try this, I want to try that. And that's fine. For my career, MDT, because I fixed my freaking neck pain in basically 4 days, when you're sitting there with yourself and you're like, and I'm consider myself, not too stupid, but I'm like, okay, let me laterally flex into my left side neck pain. And after 200 reps, I'm like, I can't find whatever was there. This is better, and my trigger point is gone. It makes you really wonder, like, what
happened? The hell is going on? Yeah.
And when you see the light, so I tell that story in every course because I lived it. It's very easy for me to teach it because I don't need to sell anything. I just have to tell the story. And most people in the audience, have a story. They're fighting neck pain. They're fighting shoulder issues, and you brought Richard Rosedale before. I mean, the XPA study is, extremity pain of spinal source. That's shaking the orthopedic world right now. There's hip surgeons and knee surgeons that are now afraid that the public will know about this stuff.
71% of the hip. Yeah, come on.
I mean, come on. How come we don't say
half
it
of
on
the shoulder.
CNN?
I mean, yeah.
46% of shoulders
Yep.
is not shoulder, it's your neck. So the public has to know that. So I'm excited as to where, MDT is going.
Yeah. Now, are you a 100% MDT purist, or do you mix and match some other things?
So I'm 100%, but once I resolve the patient problem, they come to my office. Right, I'm a business owner. I pay mortgage. I can fix you in 5-6 visits, but often there's patients that come back like, okay, can I work out with you? I'm a golfer. What can we do to do ongoing care?
Yeah.
And then I have patients who come and do, twice a week, half an hour workouts. I do other things, but come, I was an ACE certified American Council on Exercise. Like I said, 2 weeks, stupid personal trainer, passed a CPR course, and I did it. Then I did.
Subtle brag.
Then I did CSCS, National Strength and Conditioning Association. Then came the OCS, and I studied it. I'm a big believer in functional exercises. I'm a big believer in body weight training. I'm a big believer in bands. I'm a big believer in ball exercise. I believe in simple.
Yeah.
I'm not a big fan of machines. I'm not a big fan of the gym. So I incorporate other things into the recovery of function, and I make sure that the arrangement that we just repaired holds. My clients learn when they work out to check for stiffness. So if you did whatever you did in the gym, you did kettlebells, before you do that, you check for stiffness. After you do it, you check for stiffness. I have clients who do shoulder press while they're looking up because their shoulder pain goes away when they look up. There's certain things that I incorporate out of MDT into daily routines.
What do you think are some of the big misconceptions about McKinsey? Like in the chiropractic world, like people who've never taken an MDT course, they think that McKinsey's only extension exercises. But what do you think are some of the other things? Because the one thing I always say about McKinsey, I feel like within chiropractic and physical therapy, not enough people understand this. It's like they think they know, but they don't know. And we always struggle to find out, like, why is that? Like, I don't understand why that.
I think it's still an issue where the public think, or people that think McKenzie think it's extension exercise, extension protocols. People don't understand it's a classification method. You got to know what's in front of you. In part A, a lot of the time students leave the course, and I'm talking to the group I'm teaching right now. I'm like, don't just go back on Monday and, think why you're getting someone into extension. Our patient today, the first thing we did with him, we flexed him. There was no clear directional preference. So it depends on the patients you see in the course. That's what you're going to take into the clinic. Mm-hmm. The first thing we did with him today, we flexed him 50, 60 times today to see what's going to happen to his symptoms.
And I think, that's a really important point because, if the worst is if they come back and there's no change, right? If you can make them worse, you can make them better. So I think, that's one problem, not a problem, but, sometimes the clinicians are afraid and that comes back to education. You have to educate your patient that if you come back tomorrow and you're worse, well, at least we know what we're dealing with.
Mm-hmm. Yeah. So, it's... I still find it that people think all I'm doing is, and I love telling that story because everyone thinks, okay, in the neck, what's the key thing? Retraction, extension. It made me worse.
Right.
Here's why. And on day one, yesterday in the course, I asked, now this is part A, so most of them don't know the answer. Some of them work with certified or diploma clinician. And I'm like, if this and this made me worse, what am I? And then a few people in the crowd is like, oh, you're a posterior lateral with a relevant lateral component. Now I said, yes, we will understand it. And by today, they understood what it is. So my story in my neck with lateral flex, and I wrote it in my book, I needed to laterally flex towards my pain. And here is why. Just like some people need to take their hips off center.
And Yoav, how often in the cervical spine are you going lateral, would you say, percentage-wise?
Not a lot. Percentage-wise,
10?
I would say anywhere between 20 to 30.
And then what? Okay. Well, that's higher than I.
That's higher than
What about in the lumbar spine?
Including rotation. So lateral flexion and rotation, meaning going outside the sagittal plane.
Right.
I would say between 20 to 30% respond here, including headaches. You know, patients that respond to rotation away, patients that respond to rotation towards. Most people respond in the sagittal plane, but there are times, again, my case, this was needed first before I could go here.
So 20% cervical spine. What about how often you go lateral in the lumbar spine?
A good question. Probably higher. I would say, 30 and above.
Yeah.
Probably.
We've learned from Mark and Scott, like, the power of MDT in the extremities. Like, it just blows our mind every day of our life. Like the directional preference that also exists in the extremity joints. Would you mind commenting on that? Like your work with extremities?
Yeah.
Yeah.
MDT and the extremities became, Robin wrote about it one sentence in the book. But the method I developed for the spine also works in the extremity.
Milla, page 4.
Page 4, Milla.
Mark always tells the story when Mark thinks he's like come up on something, and then so he's telling Robin about it. He's like, "Oh, I'm everything you taught us about the spine is working the extremities." He goes, "Milla, page 4," and basically
one sentence. So it's evolving. Research needs to prove it more, but we see it on a daily basis. Now, if you think, let's say, someone has a meniscus tear, right? Our knees, all of us right now, our knees are bent. If I have a lateral horn or medial horn, let's say, tear, and I'm sitting all day, so basically I'm taking my tibia and my femur, and I'm doing this on a structure that right now is not sitting properly. Let's say something is torn there. So if I'm bending all day, and when I get up to walk, I feel a pinch in my knee, and you ruled out the spine, there must be a load that you should be able to find to correct whatever it is moved out of place, right? It should be.
Yeah, right.
So that's where the whole concept goes. So if you think about it, we can argue what structure it is. We can say it's soft tissue. We can, there's many things that it can move in the joint, right? We don't know what it is. But what's important is, can you load it and change the baselines?
Right.
And often the load is all you need.
Yeah.
Right.
And I think the other thing too is like every joint it applies to. Like even like I have a lot of background in the oral facial world, and it always blows my mind of how many those cases where people have TMD or TMJ dysfunction where there's a directional preference there.
Yeah. So it's interesting because I've had patients with TMJ who actually respond to protrusion.
Oh, like a lot. It's like
a lot.
Extension in the low back kind of.
And people think it's retraction. It's actually, I had more patients who worked on this and felt better afterwards. They worked on extension, or they worked on something that has to do cervicogenic first, but protrusions seem to work in my case, my patient population, better than retraction.
Right.
Is that something you find as well?
Oh, yeah.
Yeah, I think that you just got to be brave enough to invest. And that's the one thing I did actually learn a lot from Scott was like he just wasn't afraid to just move somebody 100 times in a direction just to learn. And that's what I really learned from him is he's a purist in his assessment to where like he does not take a shortcut, and I think and he told me like when he was treating patients on a weekend, he's like, my job is not to create a miracle in my patient. My job is to show the people in the seminar to expose the system, and that I thought that was really good because we're all instructors here. So I think like that it was such a powerful statement. I was like, because you feel the pressure. I think we'd all be crazy to say we're not rooting for a patient to get better, but it kind of takes the pressure off a little bit because your job with your patients today is just to expose the MDT assessment.
Correct.
If they come back tomorrow and they're worse, well,
And I have to, when I go to my hotel room at the end of every day of teaching, I have to think, what's going to happen when the patient comes back worse.
Yeah.
You have to.
Yeah, right.
And I
Yeah, you
remember, and Scott was my mentor in my when I did my probationary faculty. And I remember this patient we had, and she, in the history, she said that extension is probably what's going to be, extension is what's going to make her better. And then she had leg pain, and she bent forward, and she had back pain. And I remember we're going for dinner, and Scott pulls out a napkin, and he's like, why the hell? If she told you that she has back pain only when she bends forward, why did you extend her? I said, well, Scott, in the whole history, she said she needs extension. He said, but she was reporting central pain with bending forward. Why didn't you chase it? I was like, shit, you're right. I'm sorry. And he's like, and he would rim into you.
Oh, yeah.
No, some people didn't like him as a mentor because I was like,
I can see that.
I'm paying for it. Kill me.
Yeah.
I don't care.
Rip me apart.
Rip me apart. Make me as good as you are. Look, he and Mark, they're one of the Mackenzie boys that Mackenzie invited to New Zealand and trained them, and so they have years of experience.
Yeah.
MDT requires also. Now I'm 50. I'm much better than I was in my 40s. I'm much better. It's the amount of patients you see. Mm-hmm. It's the time you spend with other clinicians. That's one of the things I love about the Institute. I am surrounded by faculty who has thousands of patients above me in working with.
Yeah.
And so they have seen things. And so, Scott is teaching in Miami in a few months. He has an extremity course. I'm like, I can't wait to come and sit in the back of the room and just see him do his magic.
Yeah.
So,
pull a rabbit out of the hat.
Yeah.
So who are some of the other names? We've talked about Mark and Scott. Who are the other people that will blow your mind, so to speak, as far as Mackenzie?
In our faculty?
Yes.
I mean, the guy that knows his research inside out is Robert Metcalf.
Yeah,
a guy I enjoy very much. Gary Dykes, I enjoy very much. Dave Oliver. I mean, we have great faculty.
You really do. Yeah.
That and we always go, when we can, to co-teach. Josh Kidd did a lot of great, studies and doing great things with the military right now. So it's, Chris Chase. We have a bunch of great. I took courses with Cora Itona. I took courses with Christy McGuire. We all bring something to the table that is unique and different. We all, we really have a cool group of people that enjoys, teaching it.
Yeah. What makes you do this? So you don't just on a whim decide to write a book. So what was the...
So Aging Without Aching. Relieve pain, improve your posture, move better, and stop kvetching. If you open Webster Dictionary, kvetching is...
That's a word?
It's a Yiddish word for complaining. The book was called Aging Without Kvetching. People said to me, no one on Amazon is going to freaking search for the word kvetching. But if you put aging, OPTP took this and ran with it because this is my experience as a crappy personal trainer and the things that I used to recommend to my clients to do when they had back pain and they gave them temporary relief but didn't fix their problems. And so it's my thought process, it's the things that I believe that someone that gets into their 60s, 70s, and 80s, they must maintain. Like, you must be able to walk a lot. You don't need to walk an hour in the morning or an hour in the evening, but you need to break the walking throughout the day into your 70s, into your 80s. My dad is 93. He walks multiple times a day for 10, 15 minutes. You must do sit to stand. You don't need to sit in a leg press machine and press on a metallic platform. Press on Mother Earth and get yourself off your chair 20 times. Sit on your toilet and get up 20 times. That's something you have to do into your 70s, 80s, 90s.
Right.
And people think that the answer is in the gym, and it's not. The answer is right here in your environment. So the book is geared towards the baby boomers, those who want to age, with better posture. Where do we see our parents, right? People age here. Why don't we age upright? What do we need to do to change how we hang out at home? bed, television, sofa, chairs, toilet, the car you choose. I have a guy in my office now, 65, made a lot of money, bought himself a Lamborghini. Back pain and sciatica. How long did you have the back pain and sciatica? I have it for about 4 months. What happened 4 months ago? Nothing.
Sure. Lamborghini.
6 months ago, got out of his SUV, got himself a Lamborghini. Riding around Miami Beach to pick up girls. Riding hours a day trying to pick up girls. Gets out of his car, you need to see him. Like, it takes him a minute to get out of the car. And then we're talking about, choices. What are we doing? And, what are you doing? You were doing so well before in your SUV. So this is, just to put some common sense in people's mind. And here at the end, I have a picture with Robin. And basically, I'm thanking him for teaching me that less is more often.
Yeah,
Often less
that's
is
powerful.
more. It is. That's one of the most important things.
A lot of brilliance and simplicity.
Yeah. So often people, complicate things.
Yeah.
Absolutely.
So
Awesome. What a great conversation. I'm glad we got to the book. Yoav, maybe just give a 2-minute plug as to if someone hasn't taken an MDT course, or what is the number one reason someone should attend a course and start applying the principles that Robin talked about so many years ago?
Well, especially I taught a chiropractic course in Illinois a month ago. And it was very interesting to get the feedback from a chiropractor who said, listen, this method allows me to do an assessment virtually. You have clients right now, you can have an amazing hands. You can be a great manual therapist. But your client right now is flying to London, and as they took their suitcase off the conveyor belt in Heathrow, they throw their back out. So they can go to their hotel room and open up, Zoom and do or FaceTime with you. And if you know MDT, there's a very good chance you're going to be able to help them. So it's a method that gives you tools beyond the clinic to be able to manage patients around the world. And now, since the pandemic happened, the virtual world has opened a great, big opportunity for people to dive into helping the public, not only in your office. What can you do when people leave your office or when they leave the country?
Love it. Well, I love that you took a subtle jab at Jake too with the gym thing. So I'm going to have that one on repeat for him. So tell Jake to stop working out for a little bit and go walk around.
Jake is a great guy, and Jake he has his great routine. If you see him working out, and he posted it in his warm up, and how he takes his joint through full range of motion, he knows what he's doing.
Yeah, he's a smart guy.
He is.
He's a smart guy. He's a good dude. We love him. Anyway, Yoav, thank you so much.
Thanks for having me.
Man, holy
amazing.
smokes.
Great job.
Look, I can't wait to actually attend one of your courses. You're kind of our white whale. I mean, we haven't been able to be around you enough. So now we're going to be fast friends. You're not going to be able to get rid of us. So
awesome.
Go check out the book. It's on Amazon. If you go to dryoav.com, you have a lot of good resources out there. That's where the corporate wellness is and stuff like that. And then, go find that video. I'll put it in the comments. I still kind of pull up every once in a while. So
Awesome.
Anyway, have a great day, guys. Make sure assess your patients. And what Robin used to always say, your patients have the answers, right?
Sure.
Just ask them. So
just move them.
Yes. Listen to your patients and man.
Find a directional preference.
That's right. All right, guys. Well, have a great day and go look with patients. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.